who is Cody Baxter?
Yeah.
Why is he
so I'm
the expert in this?
By family medicine PA.
I did kind of tee up some things that I wanted to ask you about. So on the live today, I did promote that I wanted to ask you about continuous glucose monitor and really what the heck to do with it. And then the other thing is weight loss medications that are out right now and how you are prescribing them to your patients. And then when is the right time to start considering one? So let's start with that.
The weight loss medication side of things, right? So that's a great question. There are medical guidelines for when we would consider what we call anti-obesity medication therapy. Their BMI is still one of the criteria that is used. I will say that is based mostly on insurance coverage or FDA approval. As an obesity medicine provider, we know that BMI is a rough screening tool. It is definitely not the most accurate way to measure excess adiposity or excess fat tissue that can be adverse to many health outcomes. And so that's more of a true definition or, the disease aspect of obesity and how that might come in. But from a medication standpoint, let's simplify it, and it goes just by BMI. So BMI would be BMI of 30 or above would automatically qualify someone to be considered for anti-obesity medication. And that's where the medical definition of obesity in terms of insurance coding or anything else comes in. So BMI of 30, no other health conditions need to be considered. That's enough to be considered for medication. The second criteria might be a BMI of 27 plus any weight-related health issue that may also be contributing. That can be elevated blood sugar, high blood pressure, sleep apnea, high cholesterol, and you can kind of get pretty creative with some of those, particularly from a prescriber side if you're trying to convince that medication needs to be considered. 27 plus a weight-related health issue or just a BMI of 30 or above would be the two criteria. The one thing exception to that is South Asian populations have a different lower BMI criteria based on data showing that they carry weight differently, more centrally, and as far as adipose tissue goes. So that's the one caveat there, that we would even go a little bit lower in that population.
Oh, that's super interesting. So to figure out your BMI, we're taking
so body mass index is the only, and that's part of why it's used. It's so easy. It's height and weight, and then there's a calculation that comes from that as far as measuring body mass index. And so that for sure is one of the big reasons why it continues to be used, is it's widely accessible, or you can find a calculator online anywhere. Our electronic health records will automatically calculate it for us. So that's what we're using as far as those parameters.
And what was the most recent drug? Last time we talked, there was a drug that was just getting cleared for, I think its indication for use was just now going to be obesity or weight is it weight management? What is
they're interchangeable. I probably myself, if people ask me, refer to myself as an obesity medicine provider, but particularly within most health systems, you'll see weight management used. It's a little more widespread term, or it encompasses a greater amount of people, because when people hear obesity or think obesity, we do tend to go more towards that definition side of things, whereas truly obesity is anybody that has like excess fat tissue that they think may be affecting their health mentally or physically, and so that definition can get a little more variable. And so there are plenty of people that maybe don't meet the BMI criteria for obesity that may still benefit from seeing an obesity medicine specialist.
Interesting. Okay, because
let's say weight management. Let's just go weight management. It's easier. It kind of encompasses more. I
like that. Now, will you give everyone your background? Why are we even doing this? Who is Cody Baxter? Why is he the expert in this?
By family medicine PA, but primarily my practice for the past 3.5 years has been guided towards weight management, and that's where my true passion lies. I still see some primary care patients that are hanging on, and I love to see them, but of course, where if you let me pick, it's going to be obesity medicine or weight management where I'm doing primary work. So I have advanced certification beyond my PA, which is, PAs are generalized in terms of our background and training, which is so that we can kind of fill the gaps anywhere in the healthcare system. Within that, then I did seek additional certification through the Obesity Medicine Association. particularly for, this practice. And so have some advanced certification in that regard, and now seeing patients in what I would call a non-surgical role. So anything up until the point of bariatric surgery is something that I would, handle with a patient, whether it involves medications or just diet and lifestyle side of things. And then if we feel like there's a time and place where bariatric surgery might be the right tool for that person, I certainly have those conversations and have people that I will refer out to.
It's like a very specialized coach. And if you're looking to access someone that's an expert and help you through the journey of loss, you would be that person. You could be that person. That's a medic. Also,
yeah, actually, it's funny you say that, because a lot of times when we talk to patients about their journey, I always tell them, hey, I'm sitting in the passenger seat. My job is to read the map, but ultimately you decide where we're going. And that's, both empowering them towards whatever treatment options we might decide, but also letting them know that when you have that progress, it is not because some medication or whatever else it might have been. It's you put in the hard work and decided, to take that path that worked for you. So while some of these treatments certainly help, that they are not the true cause, as much as it unlocks the ability or removes hurdles for some people to kind of do what they already wanted or needed or know what to do, and have a little more consistency or success with it.
Yes. Help with, it's that accountability and discipline when it comes to weight management, right? It has to be consistency and
for sure. Get those. And I like to think I'm not very scary, but I know patients a lot of times are scared, so to speak, when they know they have an appointment coming up and something. So that accountability piece of just having me on your calendar, I think, is about as helpful as anything, according to patients. And so that definitely, I think, just having someone that you need to, that you're going to be talking to about it, and I'm definitely not going to scold anyone, no matter how well or how poorly it went since the last time we met. I'd like to think I'm pretty understanding in that regard, and typically those are actually the best visits we have. Is if things haven't gone well, then that's where I can hopefully provide benefit and support. When things are going well, my job is to get out of the way and let you do what's working well, right? And I don't fix things that aren't broken. I'm here when things maybe have gone off track a little bit, and help us focus or find underlying causes why that might be the case.
Yeah, you're coming up with a game plan, how to make things, how to get back on that path from the passenger seat. I like that. I love that analogy. But then I think of my driver's training guy, and he was fiercely afraid of riding with me. So okay, we do have a question. Can diet affect high
for the
blood
question?
pressure?
Yes, absolutely can. Probably one of the most direct correlations from diet and blood pressure is sodium intake. So you'll hear that quite frequently of patients who may be dealing with high blood pressure, or even later on something like heart failure, where the fluid balance within our blood vessels is very important in maintaining blood pressure. So sodium intake certainly is one of those. There is a more structured diet, and probably one of the diets that has the best and most robust scientific evidence behind it is something called the DASH diet. And the DASH diet specifically is to help manage hypertension or high blood pressure with diet. And so that can provide some really good benefit. I think you'll find it's probably not anything super crazy out there that we don't know. It's high in fruits and vegetables, it's low in sodium, it's making sure that we're getting enough fiber, a lot of these things. But it is a very structured program, because there's so many diets out there to pick from, so to speak, and they're all the best if you ask whoever is telling you. And the DASH diet is probably one of the tried and true ones that you'll find like registered dietitians and a lot of scientific research supports the evidence from.
Yeah. And is that Dash
just
like Mrs. Dash?
Just like the little boy in Incredibles.
Yeah. Dash, totally. So we have another great question. I've heard mixed things about measuring BMI. Why do some say it's not the best way to judge if you are actually overweight or
expanding
not?
a little bit on what we were talking about before is, if we were to define obesity, it is truly the accumulation of excess adiposity or excess fat tissue that can have adverse outcomes on our health or increased risk of any number of chronic health conditions. And so a term that I will use, because I think people may have heard it, even if I don't agree with it. If you've ever heard the term skinny fat, that can be a perfect example of why BMI might not be the best criteria. And that is that person by BMI, their height and weight may appear to be in a quote unquote normal range. However, if they are very low in lean mass, muscle mass, tissue, and have a higher amount of body fat accumulation than most people that are of their height and weight, that BMI is not going to catch or be a great indicator for their overall metabolic health. On the flip side, if we were to take one of the Chiefs or Eagles players that are playing in the Super Bowl this week and pull a running back aside who bounced a quarter off his abs, his BMI would probably put him in the obesity category. And so, it can go either way. And then one thing to expand on that too is I ask a lot of times, there's many ways to measure progress, but many people have a goal weight or a long-term weight that they have in mind. I use the term happy, healthy weight when we're setting those goals, because it is not necessarily going to be what a normal or even under a certain BMI criterion. So many people will say, well, the BMI says they should be this. And, the response I have for them is I don't treat numbers or equations. I treat patients. And based on how your individual genetics are, how you've carried weight throughout your life, what stage you're at in your life, what your goals are, that your happy, healthy weight can be very different, and it can be different at different times in your life. And so our absolute lowest weight is probably not where we are happiest or healthiest, comprehensively speaking, and that's where we're spending every waking moment, and it feels like having to make every single decision correct in order to achieve that lowest weight. So I encourage people to think about what your happy, healthy weight is.
Do you ever look at like the happy, healthy weight? If someone is like spinning in a bad direction, do you ever refer to
so part of what we would call intensive behavioral therapy for weight management, that would be not involving medications, more involving lifestyle interventions, and part of that certainly can be some sort of behavioral health provider. And so we try to screen for things like eating disorders. We see binge eating disorder probably most frequently, but there are other types of eating disorders that may apply, or features of different eating disorders that may apply to people who are struggling managing their weight. And then the other part, so there are some behavioral therapies that can be directed towards a disordered eating pattern. And probably more importantly, or more often, what we're involving behavioral health from is that people who are struggling with weight probably have some sort of experiences throughout childhood or earlier on in their life where it really shaped how they feel about themselves, what their relationship with food is, and how food is used in terms of possibly a coping mechanism or any number of things. Or a big one in my generation and probably younger or older is that how many of us were told like you can't leave the table till your plate is clean, right? And it's like it seems helpful, it seems like, okay, there's starving kids out there, you need to eat your food. If you're not hungry or if you're full, then continuing to be forced to eat more, it really is teaching you to quit listening to your hunger cues, right? And that can have long-term effects because it's in front of us doesn't mean we need to finish it. But that's really hard to unwire that if that's the way you were brought up and during that most developmental time of your life too.
Yeah, it's undoing that way of thinking. We have a question on fiber drinks, fiber weight loss drinks.
So fiber can help increase satiation or the feeling of fullness. So if it's a fiber supplement or a fiber type of drink, that a lot of people can find beneficial in terms of keeping them more full, maybe extending between meals without having the feeling of needing to snack. So it can be helpful for some people if you are getting enough fiber in your diet through other food sources. You might not find them quite as beneficial. And then if we do maybe take in a little too much fiber, we start running into maybe some issues with bloating or gas or some things like that too. But I think they're fairly safe. If you overdo it, you're probably going to run into those side effects more than anything, and can be helpful for some people to increase that fullness and satiation.
How about soda, regular diesel soda?
Diesel, you're talking my language for sure. Diet. Yeah. So lots of opinions on this. So I like to think of things in a spectrum when we're talking about drinks. And so over here, water is king. Plain water, any kind of unsweetened beverages. So actually like black coffee, green tea, there you go. Any of those things where there's really no additive to them are probably the safest, best options. And so water is always a great choice. If we are then on that spectrum comparing where would diet soda fall versus regular soda, particularly in the context of managing our weight, the data on regular soda is significantly more robust, that this is more likely to be associated with weight gain versus diet soda. So in a large scale, diet soda 10 times out of 10 over regular soda would be my recommendation. There is a lot of fear mongering or whatever you want to say out there as far as, you know, potential risks that link to so many different things out there. There's really nothing that is proven in that regard. Some of the studies that they do in mice or whatever it might be generally have such a high concentration of those non-nutritive sweeteners that it would be impossible for us to have that much intake. And so from a toxicity standpoint, that's just not something that we see. However, I will say on a case-by-case or anecdotal basis, some people find when they are drinking more of those non-nutritive or diet sweetened drinks, they do feel they crave more sweet foods or associate with, you know, feeling like their cravings for other sweet foods does go up. So I think it's important for us to know the large scale data, but also not discount a person's individual experience of like, when I have incorporated those diet drinks, I do feel more snacky or I find myself turning towards other sweet foods. And if that's the case, then we should, you know, minimize and keep those to a minimum.
I tend to go for the savory, salty ones.
Right. Yep.
But that's to each their own, right? And anything that you drink, like if you are drinking diet soda and it gives you a headache, and like then you know, I probably shouldn't drink diet soda. It gives me a bad side effect, right? It's being in tune with your body. I'm always so impressed with people that are in tune with their body like that. Like, oh, how'd you put the two and two together? That's very intuitive of them. Okay, so we have another question of, what are your thoughts on medications provided that are hitting the news?
Nailed it.
Such as, is it Wegovy? And are you prescribing
daily?
Wegovy?
Yeah, multiple times a day. Wegovy is a great medication overall. So Wegovy, I think it'll be most helpful if we go probably, you know, set out like names that are important to remember. So Wegovy is the brand name of a drug named semaglutide. It is also semaglutide is also the drug that is used in a brand name drug called Ozempic, which many people have probably heard of as well. Ozempic was originally developed as a type 2 diabetes medication and continues to be used for that. Wegovy was developed specifically for weight loss indication and approval, and so it is used only in weight management. Both of these drugs are the exact same drug. It's like Motrin versus Advil. They're both ibuprofen. So the actual drug that is being used is the exact same. The difference would be what they are FDA approved for based on the brand name, and then the dosing, you know, maximum dosing and kind of dosing schedule that we would use slightly different, but close enough that they are used very interchangeably. And so Ozempic probably used quite a bit off-label, which, you know, would mean that we're not using it for the type 2 diabetes indication. We're using it more for the weight loss side of things because we know that this is the same drug that is used on the weight loss side of things. And this is mostly based on availability or insurance coverage dictating this. From a provider standpoint, semaglutide is semaglutide. I don't care what the brand name is on top of it. And interestingly enough, they are made by the same parent company. They are both made by a company called Novo Nordisk. So I always in my head envision one big vat of semaglutide with two spouts. You know, I mean, it's just it's the same drug. So and you know, so Wegovy was approved second, and so that's really when a lot of popularity with these injectable medications came out. That was summer of 2021, I believe, when we got that approval. And at the time it was approved, you know, the dose it was approved at was more than twice of what the diabetes approval dose was, and so the weight loss benefit was pretty significant, and compared to any other currently approved anti-obesity medication up to that point was about double the weight loss potential. So you can imagine if we had, you know, drugs going from average of maybe 7, 8, 9% body weight loss on average up to one that had 15 to 17%, you know, that's a huge difference. Wow. And now we have a lot more people interested, or we have more popularity, we have more providers maybe willing to consider them. And so that's where things really took off. So that's kind of the background. Ozempic, Wegovy, they're all the same thing. There's other injectable medications within this class, and I'll probably talk about one really new popular one as well in that regard. But those are probably the most commonly known and the ones we hear the most about. How they work, they are an injectable medication. So when I say injectable, I mean a small injection under the tissue of the skin that you administer yourself, and it's done once weekly. And so it is a slow releasing molecule that allows that to release over a period of a week, which from a convenience standpoint can be really nice for people. When they hear it's an injection, they might shy away a little bit, but once a week most people can do. What this medication does is it works on a hormone that is primarily made within our gastrointestinal system, and that hormone has many target organs. And so one of the biggest and most influential targets is it tells the brain that we are full and that we no longer want to eat more food. So we feel that fullness or satiation signal earlier when we are eating or on a lower amount of calories in a given day. That then might give us more control over our portion sizes, types of foods we might reach for, and that sort of thing. The second thing it can do is slow down the transition of food through the gastrointestinal system so that we feel full a little bit longer. And it allows people then to go, further between meals or not reach for a snack between meals or something like that. So that's the two primary targets. In the diabetes side of things, it has a lot to do with how we process glucose, how efficient our body is at doing that, and can have some other benefits beyond that in terms of the regulation of blood sugar side of things.
So you're feeling fuller faster, but then you're feeling fuller longer, and so you don't have the urge to eat, and therefore ideally you'll have a calorie deficit if you're exercising and you're eating healthy food, and over the course of 12 weeks then you're going to have a nice calorie deficit.
Correct.
And that's when you're leading to weight loss.
A pretty good summary of it. And I will say that everybody has, just like we all have different genetics or different things that we probably need a little more or less support with, the medication will feel or work a little bit differently from one person to the next. So some people feel it that side of things. Other people feel like it's the fullness, like my portion size is just way smaller. So while those are all some of the benefits, everybody feels a little bit different in terms of how it may benefit them.
And so if someone is interested in that, do they go to their family practice provider or okay?
Yeah, so I think we're getting better at that. We still have a long way to go. So working in both family medicine, but also getting referrals from a weight management standpoint allows me to be in that position where I can kind of speak to both of them. I would say not everybody in family practice is comfortable or fully on board with the use of these medications. In the scheme of medicine, we are still kind of scratching the surface in terms of how we are treating obesity and the perspective in which we're looking at it from a medical community. So there are people who are probably much more willing and comfortable prescribing these medications. Otherwise, they might refer out to a weight management specialist or someone in endocrinology, or depending on the system and how it goes, more of a specialist. But certainly they can and should be used within the family medicine space, and that's where I would start and recommend anybody start with.
And work with someone like you that serves as a coach and has more knowledge all around.
Yeah, I think that's a big part of it too, is that it's one thing to get the prescription. It's another thing to work with someone who knows about the medication, can anticipate potential side effects, pitfalls, kind of manage expectations, a lot of those sorts of things. So yes, the getting the prescription is good, and I'm all for increasing access to the medication, but not all prescribers are the same. And kind of here's your prescription and out the door you go, versus let's talk about what it does and doesn't do, what side effects to look for, how to manage these things. It can be a much, I think, better experience for people, because there are potential side effects. There are right and wrong ways that we should be looking at how we use these medications, and that's where my job, I think, is most important.
You were going to mention another drug that we're hearing so that would be a lot about. Which one is that?
Mounjaro is the brand name for a drug called tirzepatide. Currently the only version of tirzepatide, so that one's easy enough. We can just use Mounjaro. Mounjaro currently is only approved for type 2 diabetes. Much like the experience we had with Ozempic, which eventually got studied and used for weight loss as Wegovy, they are doing the same thing with Mounjaro. The smart thing that they did, learning from those before us, as we should, is to start the obesity trials very soon after the diabetes trials, with the understanding and hope that this would have the dual benefit benefit. And so while there was maybe 5 to 7 years between Ozempic and Wegovy approval, we're going to see maybe 1 year between the approval of Mounjaro for diabetes and obesity. So we've already had the second of 2 phase 3 or later stage trials of the Mounjaro for obesity. Second one will finish here in April, I believe, and then they have fast track approval status with the FDA so that they're able to streamline the approval process once they do finish. So all that being said, right now it's a diabetes medication, but for all intents and purposes and for the long-term future, we can think about it as an anti-obesity medication as well. It is similar to Wegovy, Ozempic, all these other injectables, in that it works on one of those gut hormones that affects all the things we talked about previously. The difference is there is a second gut hormone that it also works on that basically enhances the benefit. If you think of the analogy I like to use is many hands make for light work. So if there's 2 of you working, you're going to have a better effect than one. And with that too, there is a little bit less in terms of side effect potential. So if we can get more benefit, less side effect, it's kind of a win-win all around. And so what we've seen for absolute weight loss potential in the studies so far with Mounjaro is something in that 20 to 22% body weight loss compared to Wegovy being that 15 to 17%. And so we do have quite another step up in terms of effectiveness with weight loss potential. And I can tell you from patients who have been on the medication, who have been on both, they definitely, I would say, not everybody's the same, but the majority of people do notice a difference in terms of they feel like there's a little bit more benefit, or they feel the side effects are more tolerable, and definitely have appreciated and enjoyed the transition. There are a few people that have gone back because they didn't do as well, which always can happen. But in general, I think it is an improvement on previous generations of these medications.
That is so cool. So little side effects, but they're getting great results. Wow, that's so life-changing. So to close this, I do want to chat quickly about the continuous glucose monitor that I have just started wearing. And fully admittedly, I did a hot yoga class and it slipped off. So that was a big bummer. And so I'm like, oh my goodness, I'm talking to Cody about this. But I was researching just the app and just trying to understand the complexity of diabetes. And it is a huge life change. If you are on the precipice of getting diabetes, or if you're like predetermined that you're in that category, it is a huge life change to be a diabetic. And if you can just give us, we could talk like 3 hours.
The first chapter would be 3 hours for me.
But,
if you want to talk about diabetes, it's so intertwined with obesity, and so if you know about one, you should know about the other.
Yes.
They're different, obviously, but very similar in a lot of ways. So
your body, what is it that the change in your body once
a person is diagnosed with type 2 diabetes, what has basically happened is that their bodies, the pancreas is what makes insulin being the hormone that helps take glucose from the bloodstream into the cells to be used for energy. And what has happened is the cells have less responsive to that signaling. The glucose starts building up in the bloodstream. The pancreas tries to account for that by making more insulin. And over time, this cycle continues until the pancreas is kind of the weak link in the chain, and the cells that make insulin start to burn out, or we lose function in them. So by the time you're actually diagnosed with type 2 diabetes, you've lost about 50% of the cells, they're called beta cells within the pancreas, that are responsible for making insulin. So to think that the diagnosis of type 2 diabetes is where the troubles begin is very much untrue. The whole goal is to prevent that from ever getting to that point by earlier or preventative, or looking at risk factors and treating things beforehand, because it's easier to recover from earlier on in this game. But yeah, the diagnosis is the pancreas is no longer able to regulate glucose within the bloodstream to an effective degree.
So then why now there have like NutriSense is another company that you can have a continuous glucose monitor, and their app is actually very user friendly. It talks more about if I eat a cup of rice and a cup of broccoli and then a chicken breast, how is that, or I don't think it's like a meal like that, but let's just say a cup of rice, what is that doing to my body versus when I'm using the Libre 2 app, it's measuring by grams. And then it's measuring my insulin, but I don't even know what that means. I'm like, okay, great. I'm at 100. Is this even a tool that I should be using?
Yeah, so
is it effective?
A big question on a lot of ways we can go. So I think I'd start with the way the continuous glucose monitors are primarily today used in type 2 diabetes, used in type 1 diabetes as well, which is, we'll just put in a whole nother bucket because that's more of an autoimmune disorder where we don't make insulin. So totally different. Type 2 diabetes is the one that the majority of people with diabetes have type 2 diabetes. And in that instance, what it can do is provide feedback of, hey, are there certain points of the day where our glucose levels are really high and out of range, and or are there certain foods that impact us more, or different things like that. It can also, if a person is on insulin for type 2 diabetes, help us, better target our dose of insulin that we should be using, and also avoid low blood sugar, because as much as we want to be within a good blood sugar range, low blood sugar is no good either. And so, one of the biggest things it measures is time in range, which is within a certain, low point or high point where we consider blood sugar levels to be pretty well managed. And so the more time you can spend in range as a person with type 2 diabetes, the less your chances of adverse effects from type 2 diabetes is. Where it has gotten use now outside of the realm of type 2 diabetes is that if it's just like a lot of, like we talk about weight management or these other things, is if it's helpful in type 2 diabetes, can it also be helpful in that more preventative space, right? And I do think there are instances where that can be helpful. So people who are very in tune with their body, like we talked about before, or people who do have the ability where they're overall generally pretty healthy and can devote a little bit of time and energy to monitoring these things, and then almost self-experimenting or kind of seeing what cannot make a difference or with what they do, it on a person-to-person basis may be helpful there. I will say that studies to this point, as far as like large scale use or using it as like what we consider a standard of care outside of type 2 diabetes, have not shown any significant improvements in terms of body weight or blood sugar control or things like that. But the large studies are the last thing to kind of show benefit, because they take lots of people and a longer time in order for us to see those results. And so most people that I'm seeing probably have other things that they should be spending their time or energy on, what I would call bigger rocks, to really focus on. But for the right person, I think they do find some benefit with it, or it can kind of confirm, okay, I can have a cup of rice and my blood sugar doesn't spike to 200. So I don't necessarily need to avoid a cup of rice as much as it's a cup of rice with a tortilla with beans with margarita, right? Or something else.
I guess that does make, then I was using it, right, to measure, like I would measure right after I ate. So should you measure it like an hour?
Yeah,
when do you start to metabolize the food?
Basically, depending on the food, it can be different, but about 2 hours after a meal is where we can expect the peak of blood sugar to be. So a lot of times with patients who are using insulin, one of the things we'll talk about is where are your fast glucose levels, what is the lowest it's getting, and then what is the glucose level 2 hours after your biggest meal of the day, which would typically be the highest throughout the day. So that gives us an idea of where their range of blood sugars are going throughout the day. And that's like if they have the old school like meter where you're pricking your finger and taking blood sugar. So the continuous glucose monitor takes away all those finger pokes, which is nice, but also gives us more continuous, as the name would imply, data versus just specific data points that a finger poke would. So it's really cool to see the report, particularly in my patients with type 2 diabetes that have been able to utilize them, because it gives us just way more data than we could ever do anything with, to be honest. But it does really help say, hey, look, between 3 and 6 p.m. you're having these spikes. Like, what do you typically do in that time of day? Or, mid-morning when we really shouldn't be having too much of a spike, or any of those sorts of things. And so it can help us really more micro-target points of their day, or maybe behaviors that they weren't even realizing were working against them in terms of glucose control.
Yeah, and then you could put those symptoms that you're having, like, or the way that you feel, and align it with then, okay, this is what my insulin is doing to this is what I ate. And that's why I got it, is because I just wanted like a full story of how is this food that's affecting my body, or how is it affecting my body, the food that I'm putting in my mouth. And so I can have a comprehensive understanding, rather than just like, I should eat these times a day. And now I just need more of a comprehensive understanding of what it is that I'm doing, and it falls off my arm. So do you have anything for that? I saw a sock. This guy's like, just cut a sock and put it on.
I mean, that could be part of it. I know there are some that go more like on the abdomen, are less likely to fall off, but I think that speaks to probably one of the pitfalls, or one of the things that we need to consider is like, if a patient, if we're having like a patient who is, let's say, drinking 6 regular Cokes per day, for instance, I don't really need a continuous glucose monitor to know that they're probably having some, spikes in their blood sugar throughout the day. And I probably would prefer that they spend their, time and energy on focusing on ways to reduce the Coke intake before I'm worried about trying to get them to, keep their the glucose monitor on, or work with the app or some of these other things. And so that's where, when we talk about widespread adoption or standard of care use, is that it's probably much more of a targeted or cherry on top sort of thing versus like a big rock thing. But for people who are able to do that and have that ability, a lot of people find it to be pretty useful.
You want that person to figure out how are they going to switch that second Coke with a water.
Yeah, how can we reduce and make some progress in that respect, and then we can iron out the fine details down the road. So if we're at a point where we're thinking about a continuous glucose monitor, we must be in pretty good shape overall, is what I would say.
Well, this was so fascinating, Cody. You are just a wealth of information. Thank you for taking the time to join us. And I bet that I'll have more questions afterwards. So if you want, we can do this again. And because I know you're an expert in another field, which is aesthetics, and a lot of interest in that area as well.
Yeah, I would love to come back. I think we, you could put a quarter in me and probably walk out the room, and I'd still be talking depending on the topic. And so happy to come back anytime, and I really, truly just love to help and I think spread, evidence-based and helpful knowledge for people in this regard, and try and wade through all the different information out there. So happy to come back anytime.
And we'll have everyone follow Cody too. He's got a new Instagram handle. So, and he needs some followers. So get on there, because he's going to put really good information up there.
Been put on blast now, so now I have to start posting. So I've had the handle for a while, and now I need to start putting content out there. So here's just for that.
Yep. All right, Cody, have a great afternoon. Thank you again. And thanks for joining.